RightCare moments. One of these action points where you can get patient engagement, and if we can help them maintain control, then they're both at high risk later, even if it's only onset during pregnancy, but to help them have that nudge right then. And it seems like you may have gotten results in this area, and I don't know if Kaiser's looked at what's happened with the pregnant population. Have you had better control, or if there's been any impact on outcomes? Do you know if you've looked at that, or?
We, whole blood pressures are key for pregnant patients. That's, that's it's a completely different standard. I'm unaware of data on results. I know the literature on pregnancy is to, reduce the highest, blood pressure, and there's certain medications and so forth. But
Well, we know from recent work both the amount of increase during pregnancy, whether it's an increase cutting across, going from what at a given point in time is considered low to high, and new onset of hitting hypertension or independent predictors of preeclampsia.
I'm sure we have that. There are at least 5 different types of pregnancy-related hypertension.
Mm-hmm.
And probably our OBGYN have some data on that. I'm not aware.
The other thing I just wanted to commend you on is that the part of what the way you achieved this through having all of the screenings be done at a high quality, every test in high quality, is defragmenting care. Is taking it from something that only gets assessed if somebody's coming to their primary. It only gets assessed by a subset of the system, to making the threshold for getting a blood pressure check, a quality check and feedback much lower. And I think that's part of what's addressed the racial difference. Is if you're seeing anybody, you get checked. I can remember Alan getting checked when he was in for a chemo appointment, and being told him, "I'm sorry, you have your measure hits hypertension." He was like, "That's really exciting. That's data I love. I'm glad you're doing that. Not my biggest problem today, but that's data they love." And it turns out the cancer medication he was going on at the time reduces your blood pressure extremely. So it was less of a concern.
Yeah, so that's really important. There are a lot of chemo drugs that increase blood pressure. So.
Decrease.
Some decrease, some increase. It varies.
Bevacizumab is one that increases. The VEGF inhibitors increase blood pressure. So
Well, he's on TKIs, and the different TKIs, some of them happen to have hyperlipidemia effects, and some of them have hypertension.
Well, that was very, very impressive. And the one last thing I'll say as we transition to Jean Handler, I'm sorry, Jean Shahdadpuri, is the connection to heart failure. And I know we can't really get into that today, but hopefully you can connect us with some of your heart failure specialists, as that's a topic that we're working on as well.
absolutely.
And have you seen your heart failure group decline as your?
There's that's an incredible testimony to team-based care. My gosh, keeping heart failure patients, titrating them, teaching them, and then there are different programs depending on the type of patients, and so our rehospitalization rates at Kaiser are way, way lower than anybody else because of the team-based approach.
So as your hypertension control has increased, have you seen your population of heart failure patients decrease?
That would be tough data to collect. I pointed out the most, the older trials, observational trials with blood pressure showed the first thing that people get with uncontrolled hypertension is not stroke or MI, usually it's heart failure. And as a matter of fact, the Cardia study was a 20-year observational study reported in New England Journal of Medicine with African American patients, showed that 1 out of 100 African American patients will develop heart failure before the age of 50, and three
There's a project,
quarters of them have hypertension.
What was the number again?
1 out of 100.
1% of
Yeah,
of
and
those
that's 20 times
under
higher.
age 50.
That's 20 times higher than the rate of incident white hypertension. So that's a Cardia trial in 2009 New England Journal of Medicine. So that's why we need to apply additional resources to that, population because of the consequences.
Well, we look forward to following up with you on that. Thank you so much. Round of applause.
Oh, thank you. That was fantastic. I was going to refer to you as the father of controlling hypertension, but I think I'm going to label you the Google of hypertension, so that anything we need to know, I think you know. I'm now going to introduce Jean Shahdadpuri, whom I know well. She's with my organization, and she's the Vice President, Senior Medical Director for Health at Centene in California. And she has a lot of roles. She has a lot of hats that she wears underneath that one big umbrella hat. She really works with our provider groups, as we've been talking about. Kaiser's a different kind of system than we and the rest of managed care have. So one of Jean's big roles is working with our provider groups to be a liaison and help us provide them with what they need and them provide us with our patients' need. Members. So she has a big role in that. Her past history you can see in the bio, which is really remarkable. She's had a lot of experience in different models of managed care, and she's been the CMO there and a lot of other things. So we are glad to have her in our organization, and Jean, I'll hand it over to you.
Thank you, Carol. For that introduction. So coming from Kaiser to the real world, we're lucky to have Kaiser in California. The other components of the healthcare industry and other health plans are significantly different. So we do have a lot of challenges that we deal with. That Kaiser privilege not to have those. So my presentation is on the update for HealthNet and California Health and Wellness. My objective after those really heavy presentations will be if everybody could just take away from here. One thing is if they come across any patients with hypertension, heart disease, and diabetes, to say, hey, are you on the cardiovascular bundle? Are you on the aspirin, statin, and ASR? Clinical or non-clinical people. To just have them at least go ask their doctor about those medications. So if there's anything you take away from my presentation, it's just that, and that would be good. So a quick introduction to our organization. We were acquired by Centene Corporation, that's based out of St. Louis, about 2.5 years ago now. They're present in 31 states. We are now the largest Medicaid health plan in the US. We're in 2 international markets, which is actually not Puerto Rico, Mexico, it's actually Spain and UK. We have 14.4 million members. They are number 1 in Fortune 100, but what is even more attractive is they're number 49 in the fastest growing companies, and it is a pretty aggressive organization in terms of growth and diversification and expansion. An example of that is they just acquired the Fidelis health plan in New York with about 1.6 million members, out of which about 65,000 are Medicare and the rest are all Medi-Cal or Medicaid. There are about 45,000 employees. Centene had a footprint in California with California Health and Wellness up north. That was a completely fee-for-service Medi-Cal health plan, now a big footprint in California with HealthNet. So that's a quick introduction on our organization. I think, John, you had asked the previous speaker on the distribution of the membership. So about 2 million Medicaid or Medi-Cal, that includes the California Health and Wellness. Medicare, about 150,000, commercial members, about 850,000, dual eligibles who are Medicare and Medi-Cal, about 14,000 and growing. And the structure here is you have the fee-for-service providers that pretty much get paid for all the services they provide and submit a claim, versus capitated providers that are generally part of big medical groups, and they submit encounters. Because they're capitated, they don't have to submit, for lack of a better word, a bill to get paid, so they submit something called capitated claims or encounters. And this is important to know just because that's our only way of capturing any information or data from the providers about our membership on what services they've gone through or what diagnosis codes they have. We have an integrated approach here in our organization. So member being in the center, we have care coordination, benefit management, all the IT systems supporting us, and then person-centric programs. For the benefits, we have a lot of life, health, and wellness benefits. We have pharmacy and specialty pharmacy, dental vision, telehealth, which is actually a whole other department taking a big strategic focus right now, and we actually have a strategic plan with quite a lot of funding going into telehealth. In-home services, so trying to get to the member in their home setting, care management, et cetera, et cetera. Behavioral health, I mean, I should, behavioral health is a big component of what's now getting integrated into our medical services. So this initiative that I lead at HealthNet and California statewide is mirrored or mimicked after James Duggal, and I did happen to meet him last year in Berkeley, which was really nice. It's good to see him alive and kicking, and probably on the cardiovascular bundle.
He's going to be speaking at our Stanford group in 2 weeks, and he's going to be teaching on, how the simplified bundle is a way to move patients very quickly into good control.
So if I can get that, maybe I will.
I could see that Dr. Handler's just blushing here because he was really the creator behind the scenes of a lot of what Jim is implementing.
No, Jim started the half-tablet approach with metformin, and so, that was, came before our half-tablet approach. Jim was unbelievable.
So this was a long time ago, but it still was about a significant amount of membership, 170,000. These were all diabetics or people who had cardiovascular disease, and they were put on aspirin, statin, and a calcium channel blocker, and had significant impact on decreasing heart attack and strokes and decreasing inpatient days in the hospital. So we took this as the baseline and tweaked it a little bit, and kind of got all membership with the primary or secondary diagnosis of diabetes that had any kind of history of heart disease, hypertension, and so diabetes, hypertension, and heart disease, and put them on any category, any medicine in the category of ACE inhibitors, statin, and aspirin. Now, this is also part of the undertaking that we have to abide by because of the merger with Centene and HealthNet. That actually gave us the impetus and the funding and a purpose, so I'm glad that happened. Of course, it's taken a life of its own now, but that was the impetus to start something like this. So this is on diabetes and heart disease. We know anybody with diabetes has a 2 to 3 increased risk of heart disease, has a 30% rate of coronary stents implantation, has about 280,000 heart attacks annually, has a 2 to 4% higher heart disease morbidity and mortality rates, and 60% chance of dying of heart disease. Now, when we took all the data from our organization statewide and pulled all the diabetics, and then kind of checked for how many of them were on the cardioprotective bundle, a shocking figure came up, which was about 40% were not on the cardioprotective bundle. Now, last year, Hattie, I presented 60% were not on the cardioprotective bundle. So
congratulations.
A lot of them, probably don't know that difference. 20% is huge for us. So now, even though it's in the red, I still take pride that 40% are not on the bundle. So we have a denominator of almost about 200,000 members. that we are addressing and engaging in this initiative. HealthNet also earned a national recognition award for working with AHA and AMA and participating in their commitment to work on increased high blood pressure and reduce the chance of Americans getting heart attacks and strokes. So our initiative is to decrease and prevent strokes and cardiovascular events in this highly targeted, high-risk population. This also goes along with our triple or quadruple aim of improved population health, improved member experience, and lower cost. The way we are doing this is we share best practices of care, we share resources, we educate members as well as our providers. And the way we do this is our secret sauce, which is we actually use healthcare coaches. So we engage this membership with healthcare coaches that are either diabetic educators, nutritionists, pharmacists, dietitians, but essentially they are people who have more luxury of spending time and understanding the patient's needs, and have training in motivational interviewing as well. And they engage with the member to find out whether they're aware of their condition, what medications are they on, if they have any barriers, or any hurdles in staying adherent with that medication. The frequency of engagement with these coaches is determined by their equity and risk and motivation levels of these members. So that, I think, is the secret sauce that actually now in the second year of our implementation has yet to show an impact this year. This is just the prevalence of diabetics in California. So higher incidence of diabetics or density of diabetics in LA, San Diego, and Fresno region. This is up north, so Imperial County and Butte County have the highest density of diabetics up north. So this just shows the supporting activity. So when we went for this initiative, and a few of my colleagues who are our right-hand people in quality who are doing this, and we decided how to engage our providers and members, we looked at it a little more wholesome picture on how do we address the member. So it was not just addressing them for the cardiovascular bundle, but we started developing programs that was addressing more of a whole person care model or a whole person condition model. So we have several support departments that actually engage with our members and providers. For our providers and provider groups, we have regional medical directors and clinical program managers that Carol was describing that go and engage with the provider groups with the list of providers that have this membership that are on or not on the cardiovascular bundle, along with their comorbid conditions. We also have Omada, who's our online coaching vendor, who engages with our membership. It's more of a peer-to-peer motivational engagement tool, which actually encourages the members to talk amongst each other, and there's always a coach there. We have pharmacists, so like Scott had described the role and the value that pharmacists provide. We just got an approval to hire 10 FTEs, pharmacists and pharmacy techs, which is amazing because I think everybody sees the value in a pharmacist touching, titrating the medication, engaging with the members. For RightCare initiative, we actually have 2 dedicated pharmacists that have been doing this work for the last year. We have med adherence vendors, like we have IVR calls, but also pharmacist calls, and then we have TowerView, that's actually an electronic pill box vendor that provides pre-packaged pill boxes to the member, and each time the member forgets to take a pill, there's a message that goes in on their cell phone to say you've forgotten to take the medication. My strength My Strength is an online engagement tool which is really good, and it's not just for diabetes, but it's also for depression, weight loss, diabetes, hypertension, and that's more of a self-paced member online engagement tool that actually helps the member understand their condition, set their own goals, and kind of leads them at their own pace in their own comfort zone. So, so this is just to show that you probably need to address this issue with any way that the member would prefer or the provider would prefer. So we can't just simply go one track with one way to approach this. It's really how the member wants to be engaged. It may or may not be in the PCP's office. What Joel said, it takes 3 hours out of their day. So we try to see any way that is a preferred way to engage with the member so that they're comfortable understanding their condition and getting convinced on why they need to be on this medication. This is important for anybody who's trying to do this initiative in their organization. This helped me get a lot of traction and support from quality department because it actually impacts 6 of our HEDIS measures that we are held accountable to, and there's money attached to it. CDC, persistence of beta blocker treatment after heart attack, statin therapy for diabetics, statin for cardiovascular disease, controlling blood pressure, and NPM measure. Now, when the coaches are calling the members, they're actually addressing all of these in that same call. So, so a big objective of this initiative was to avoid member abrasion. Not to have multiple people calling from the provider office, from the health plan, from the PPG, which is a provider group, or the IPA, or the vendors that are involved and work with the health plan. The purpose was, how do we make that one effective touch and decide on who's the best person to interact with the member to address all their concerns. And we figured the coach was the best first point of contact. Now the coaches have an escalation route if they're not a pharmacist and do need pharmacy support, they have an escalation route and an access to a pharmacist. They have access to an endocrinologist. They have an access to psychiatrists and our claims shops or the copay department. So if the member says they have a copay issue, then they do have a way to either go into some of the resources they have or get in touch with somebody who can actually sort out the copay issues. So convert it into mail orders or see how we can help them with their copays. So these are the results till date. We only launched this in March of last year, so it wasn't even an entire year. We have savings for a lot of millions of dollars already, and that essentially came around by decreasing the utilization rates around cardiovascular events. So the way we measured savings was not overall PMPM cost of the member, it was very specific to the cardiovascular conditions that the member had. We wanted to make sure whatever intervention we have is impacting the cardiovascular events and not like asthma or motor vehicle accident or any of that. We did find patient engagement increased at 12% to 76%, and PMPM costs by line of business reduced by the percentages that I've listed there. This year, I'm expecting the impact to be much, much higher. So member outreach activities, provider outreach activities, we have reminders that go through mail, IVR calls, live calls, text messaging. We are in the process of getting a database of members' mobile numbers and email addresses as a new way to interact and engage with the members. That's happening this year. We are looking at developing a few apps and trying to see if that's the way the member would like to engage. Incentives for the members to either come into the office or get the service done at the lab, in-home visits, health education classes that are held either at the clinic or at a community resource center. Provider outreach activities are a lot, and that includes providing the best practice tip sheets, toolkits, educational webinars to be held at their convenience recorded and not recorded ones. Care gap list. So this is interesting. Each provider has something called a care gap list that lists out all their members that are missing a measure, a quality measure, or a breast screening measure. We have managed to get something called a RightCare initiative measures that is in their care gap list, which they're very used to seeing for years. We had to make sure there was something the provider was looking at that was part of their workflow and not an additional list that was coming through. So they have now the members that are not on the cardioprotective bundle in their care gap list, and they can see which medication they're on or not. The caveat is aspirin is the only one that's not on there because it's over the counter and doesn't make it through the claims always. So that's the part that is more understood or verbal, and it's not really recorded through the claims. We have joint operation meetings with the groups. So the way my team is doing this is they find a clinical or non-clinical champion who's very passionate, somebody like Hattie, or very passionate about making a difference. I say that because it's not that person that generally does all the other things, so they have less bandwidth to do this. This is a person who's ready to take this on, so this person gets all the lists of all the docs that have the membership that are not compliant with the cardiovascular bundle. And this is sometimes a quality person, medical director that's handling something else, or actually in one case, a non-clinical person who's an IPA administrator. That person has gone to the provider offices and shown these lists of who are these members. And the way I have the packet designed for them, it says, what are you doing, doc? That's the first line. What are you doing, doc? These are the members who have trusted you as their PCP, have the highest risk with heart disease, diabetes, and hypertension, and they're not on the basic medications of statin, aspirin, and an ASARB. So it gets their attention. Like a lot of people here said, docs don't like to be told that they don't know what they're doing. But it gets their attention and it gets them to work on it. And then of course the peer-to-peer comparisons there, which I leave it up to the group to make it blinded or not. There's some groups doing it unblinded, there's some who are doing it blinded. I encourage them to do it unblinded. So they have that comparison of the doc next door to me having 70% compliance and them not having that compliance rate. But it actually says, what are you doing, doc? And the next sentence says, do you know your member could be having a heart attack now? Do you know it's because they're not on this medication? So the first two sentences, I don't know, a lot of discussion went around it, but I think it's making an impact, so that's it there.
It's bold.
That is bold. Now these are some slides that actually show our performance by line of business. So I'm sorry there are a lot of these slides and they're not the most interesting ones, but the way to look at these is their measures are on the left. This is the CDC measure. Here you have the individual counties. So each county has the Medi-Cal 1 plan or 2 plan. And oranges are bad, blues and dark blues are good. The first line is 16, the next line is 17, and the last line is 18, 2018 reporting year. We have made some significant improvements, although in some of the counties a lot is still to be desired. So all the oranges, like San Joaquin, Sacramento, these still have a lot more opportunities still to be.
Could you elaborate on that center component for Los Angeles County, since that's what we're focused on right now?
So this is for Medi-Cal line of business, LA County. The 18 is the last year, or the most recent year. The blues are the good. The dark blue means that we're already 75th percentile and above in this particular measure. The orange is where we are below NPL for hemoglobin A1C more than 9%. Does that make sense? This is for controlling high blood pressure. Again, LA being here, blue's good.
Look at that. Control blood pressure.
We're at 50th percentile, still not
Better.
happy, but better, but
Better.
better. This is better, which is statin therapies.